Here, do you want this chair? And I can just pull yours out here. Have a seat, young lady.
Young lady.
Excuse me, young woman. Grab a knee.
Well, good afternoon again. We'll get started. Again, we're excited to have the Helena Indian Alliance present to us today. Our presenters from the Helena Indian Alliance are Amy Nelson, Tara Wells, and Jason McNeese. So without further ado, I'll turn it over to Amy Nelson to get started. Amy?
Thank you, Mark. Hi, my name is Amy Nelson. I'm a registered nurse and I work at the Medication-Assisted Treatment MAT at the Helena Indian Alliance. And I have Tara Wells with me and I'll let her introduce herself.
Hello, my name is Tara Wells. I'm a family nurse practitioner. I've been a WIGARD provider for almost a year. It will be a year in May. Prior to coming here, I was a registered nurse for 12 years, and addiction has been my passion of treating patients with addiction. Jason?
Hey, good afternoon. My name's Jason McNeese. I'm a state licensed behavioral health peer support specialist at the Helena Indian Alliance in Leopocha Clinic. I'm an opioid addict in recovery. I work closely with Tara Wells and Amy Nelson and with the patients using the medically assisted treatment program here to provide additional supports and community resources. Additionally, I work with mental health peers, peers in mental health recovery as well.
Okay, do you want to get started on the first slide?
Amy, you have, there you go.
Okay. Okay, so our first slide, medication-assisted treatment, MAT, is the use of medications in combination with counseling and behavioral therapies, which is effective in the treatment of opioid use disorders and can help some people to sustain recovery. Opioids are a class of drugs that include the illicit drug heroin, as well as the illicit prescription pain relievers, oxycodone, hydrocodone, codeine, morphine, fentanyl, and others. So that's our main goal here at MAT, is to assist people in recovery from these opioid addictions or use of illegal drugs on the streets. Go to the second slide.
So goals, more must be done to facilitate treatment options and the development of therapies to address OUD as chronic disease with long-lasting effects. So this means that helping more people secure medically assisted treatment, which requires us to break the stigma often associated with some of the medications used to treat OUD. Thus requires us to find new and more effective ways to advance the use of medical therapy for the treatment of OUD. Just for example, the national average of people who stay clean after 1 year of being on a medically assisted treatment that includes medication and therapies is 75% of people stay sober and clean off of illicit drugs and alcohol.
So our medically assisted treatment program is a little bit unique in the fact that we require participation in peer support services, as well as participation with a licensed addictions counselor. So after running our numbers with about roughly 13 months of data, the numbers are coming back at an 80% success rate. So that's to say that 80% of the persons that struggle with OUD stay sober for that full year or longer than that with our program.
And medications used are, there's 3 different drugs approved by the FDA for treatment of opioid dependence, and that's buprenorphine, methadone, and naltrexone. Here at the clinic, we use the buprenorphine, and that comes in different forms, including SUBOXONE, Subutex, Subzol, and then the Sublocade injection, which we are promoting currently and do have some clients on it. And all of these treatments have been demonstrated to be safe and effective in the combination with counseling and psychosocial support. Everyone who seeks treatment for OUD should be offered access to all three options, as this allows providers to work with patients to select the treatment best suited to an individual's needs. Due to the chronic nature of OUD, the need for continuing MAT should be reevaluated periodically. There is no maximum recommended duration of maintenance treatment. So it really is an individualized plan. We do have a contract that clients sign, and so they're aware of the guidelines and the rules that need to be maintained while they're in the program, but it truly is individualized per patient and what they need.
So opioid addiction, opioids are chemically related and interact with opioid receptors on nerve cells and brain and the nervous system to produce pleasurable effects in the reward center of the brain. So Montana mirrors the national average for opiate overdose, 5.4 per 100,000, and this was in 2013 to 2014. More than 15% of Montana high school students report misusing a prescription opioid, and the number of arrests involving heroin has more than tripled since 2014. Opioid use is the primary driver of drug overdose in the state of Montana. 44% of all drug overdose deaths are attributable to opioids. Montana has made progress in recent years addressing prescription opioid misuse and abuse and reducing overdose deaths, though much more can be done to ensure that opioids are prescribed, taken and disposed of safely, and that patients are being transitioned off high-dose prescription opiates, and they do not transition to illicit narcotics such as heroin. This has been a big problem recently because I know that the state has been reviewing how much people take, and I know the Board of Pharmacy is really hunkering down on providers, and which causes us to take our patients off of opioids, and then they turn to something else, or suicide, unfortunately, because they feel like they're not being taken care of. So that's why medically assisted treatment is such a great option for people, because it really does help with pain as well as addiction issues. And then we really try to address mental health issues that are untreated or undiagnosed, because that's a huge proponent of people having addiction problems.
And just more about addiction. Addiction is a primary chronic and relapsing brain disease characterized by an individual pathologically pursuing reward and or relief by substance use and other behaviors. Of the 20.5 million Americans 12 or older that has had a substance use disorder in 2015, 2 million had a substance use disorder involving prescription pain relievers, and 591,000 had a substance use disorder involving heroin. So those are pretty alarming numbers. Oops. And then just a slide here displaying almost 18 out of 100 Americans have used illicit drugs or misused prescription drugs.
So a lot of these statistics that we're working with here are from 2013 to 2014. As we all know, this is at the beginning of the opioid epidemic, and so these numbers have increased substantially. It's been estimated that most of these numbers involving overdose and the abuse or misuse of opioids have doubled.
And then here's a slide too, just showing the increase of the drugs here: methadone, natural and semi-synthetic opioids, heroin, other synthetic opioids, fentanyl and tramadol. Fentanyl's a big thing now, and there's other derivatives of fentanyl which are much stronger. People are overdosing, and then any opioid rising at the top there.
So included with our medically assisted treatment program and to help to combat overdose deaths in Montana, we also have implemented a Narcan and naloxone training program that we hold quarterly. This program can be accessed in the state of Montana through Best Practice Medicine, who would come out and train master trainers at your facility. It's kind of like a web theory. The more master trainers that are trained, the more general users can be trained within the community. Last year we trained 55 general users and 55 general users and 35 master trainers. So the master trainers are able to go out into the community and train general users, and then the Narcan is also provided free of charge.
So overdose deaths involving synthetic opioids, death rates involving synthetic opioids other than methadone, which include drugs such as tramadol and fentanyl, In 2017, more than 28,000 deaths involving synthetic opioids occurred in the US, which is more deaths from any other type of opioid. Also in 2017, the largest increase in synthetic opioid overdose rates was in males aged 25 to 44. Deaths from synthetic opioids significantly increased in 23 states and the DC from 2016 to 2017. West Virginia, Ohio, and New Hampshire had the highest death rates from synthetic opioids.
And so if we're also talking about ways to combat opioid overdose, and Narcan being one of those, it's essential to have Narcan or Narcan trainers at your facility for teaching harm reduction, risk prevention with users that aren't willing to stop using or users that continue to relapse into opioid use, having that Narcan training available for themselves and and their family members, and having Narcan on hand or available for them and their family members can help to prevent an overdose death.
Synthetic opioid overdose death rates other than methadone increased across all demographics, county urbanization levels, in numerous states. State reports have indicated that increases in synthetic opioid-involved deaths have been associated with the number of drug submissions obtained by law enforcement that test positive for fentanyl, but not with fentanyl prescribing rates. These reports indicate that increases in synthetic opioid-involved deaths are being driven by increases in fentanyl-involved overdose deaths. And the source of the fentanyl is more likely to be illicitly manufactured than pharmaceutical. So as we just discussed, that's a large problem that's increasing. There are also fentanyl analogs such as acetylfentanyl, furanfentanyl, and carfentanil, which are similar in chemical structure to fentanyl, but not routinely detected because specialized toxicology testing is required. Recent surveillance has also identified other emerging synthetic opioids like U47700. Estimates of the potency of fentanyl analogs vary from less potent than fentanyl to much more potent than fentanyl. But there is some uncertainty because potency of illicitly manufactured fentanyl analogs has not been evaluated in humans. Carfentanil, the most potent fentanyl analog detected in the US, is estimated to be 10,000 times more potent than morphine. And so toxicologists are working on trying to keep up with this too, but as the chemical structure changes, like when they're doing autopsies and whatnot, they're not able to identify all of it, but they are working on that.
So county level opioid prescribing in the US from 2015 to 2017, a recent study shows the amount of opioids prescribed in the US decreased by 20.1% from 2015 to 17, with reductions in 74.7% of counties. Despite reductions in prescribing, opioids continue to be prescribed at nearly triple the amount prescribed in 1999, and opioid overdoses continue to increase, driven largely by illicitly manufactured fentanyl. Coordination across multiple sectors, including public health, healthcare, and public safety, can reduce the burden of opioid overdose epidemic.
The overdose prevention in states efforts. CDC is working with 45 states and Washington, D.C. to provide scientific expertise, enhance surveillance activities, and support resources to report non-fatal and fatal opioid overdoses more quickly, identify hotspots, and rapidly respond with targeted resources, identify risk factors for fatal overdoses, increase comprehensive toxicology testing and support to medical examiners and coroners, share data with key stakeholders also working on prevention activities, share data to improve multi-state surveillance in response to epidemic, enhance prescription drug monitoring programs, implement and evaluate strategies to improve safe opioid prescribing practices, and share CDC's prescription awareness communication campaign to increase awareness and knowledge among consumers about the risk of prescription opioids. Oops. And around 46 people die every day from overdoses involving prescription opioids.
So buprenorphine, this is the main component of the medication we prescribe for medically assisted treatment. It was approved for clinical use in October of 2002 by FDA. Buprenorphine represents the latest advance in medically assisted treatment. Medications such as buprenorphine in combination with counseling, behavioral therapies, provide the whole patient approach to the treatment of opioid dependency. When taken as prescribed, buprenorphine is safe and effective. Unlike methadone, which has to be given in a very highly structured clinic, buprenorphine is the first medication to treat opioid dependency. And it's honestly probably one of the most safest drugs I've prescribed. especially with the SUBOXONE one. So the SUBOXONE is buprenorphine with the naltrexone in it, and that's the main medication that I prescribe to people. Very rarely do I need to prescribe a Subutex unless somebody has a documented allergy against the naltrexone, which is very few and far between. And then the Sublocade, which is just buprenorphine, is a once-a-month injection that goes in the subcu tissue in somebody's abdomen, and so they have just the constant delivery of the buprenorphine. And just a side note, just 16 milligrams of buprenorphine blocks 90% of the receptors in the brain, which kind of shut down your reward center a little bit. Unfortunately, people can still get high if they use meth on buprenorphine. They're still kind of working on coming up with a medication to try to combat the meth crisis that we have. But buprenorphine blocks opioid. I mean, it will not have any effect at all, or heroin, or morphine, or anything like that. So I get the question a lot about people who might have to have surgery or something like that to treat acute pain, because we do need to treat people's pain as well. So what happens is they wean people off the buprenorphine, and if that's not possible, then they'll usually do some IV fentanyl at bigger doses to help with pain management. So just under the Drug Addiction Treatment Act 2000, the Data 2000, qualified U.S. physicians can offer buprenorphine for opioid dependency in various settings, including offices, community health, health department, or correctional facility. And just within the last couple of years, have nurse practitioners and physician assistants been able to prescribe that as well.
Okay, so we'll talk about SUBOXONE now. At 16 milligrams of SUBOXONE, 90% of the receptors are blocked in the brain. Buprenorphine suppresses and reduces cravings for the abused drug. It can come in a pill form, sublingual tablet, or sublingual films that is placed under the tongue. Naltrexone works differently than methadone and buprenorphine in the treatment of opioid dependency. If a person using naltrexone relapses and uses the abused drug, naltrexone blocks the euphoric and sedative effects of the abused drug and prevents feelings of euphoria. Buprenorphine is an opioid partial agonist. That means that, like opioids, it produces effects such as euphoria or respiratory depression. Effects are weaker than those of full drugs such as heroin and methadone. Buprenorphine's opioids effects increase with each dose until at moderate doses they level off, even with further dose increases. This ceiling effect lowers the risk of misuse dependency and side effects. Buprenorphine's long-acting agent, many patients may not have to take it every day.
So misuse or diversion is a pretty big concern. That's why they developed the Sublocade injection, which is the once-a-month injection. They come to the office, we give them the medication, and then they're good for another 4 weeks. The shot does last up to 6 weeks, though, just depending on if there's scheduling conflicts or whatever. So that's nice. But because of buprenorphine's opioid effects, it can be misused, particularly by people who do not have an opioid dependency. Naloxone is added to the buprenorphine to decrease the likelihood of diversion and misuse of the combination drug product. So if somebody was to smoke or inject the SUBOXONE that has a buprenorphine and the naltrexone in it, the naltrexone is what would hit the person's neurotransmitters first and throw them into pretty bad withdrawals and detox. However, I have also heard from a few patients that once that goes away, then you do have the euphoric effects after that. So it's not necessarily totally foolproof, but it's helped scare people, because that's the biggest thing that they don't want to happen, is to go into withdrawals. And then again, with taking the SUBOXONE, when you take the SUBOXONE orally as it's prescribed, as soon as the naloxone or the naltrexone, both the same thing, hits your oral membranes in your mouth, it's pretty much null and void. So really, it's just there to prevent misuse, so being injected or being smoked. So when these products are taken as sublingual tablets, buprenorphine's opioid effects dominate, then naloxone and naloxone blocks opioid withdrawals. If the sublingual tablets are crushed and injected, the naloxone effect dominates and can bring in opioid withdrawals. Side effects for Those of opioids can include nausea, vomiting, constipation, muscle aches, cramps, cravings, inability to sleep, distress, irritability, fever, diaphoresis, all that lovely stuff.
Patients on naltrexone may have reduced tolerance to opioids and may be unaware of their potential sensitivity to the same or lower doses of opioids that they used to take. If patients who are treated with naltrexone relapse after a period of abstinence, it is possible that the dosage of the opioid that was previously used may have life-threatening consequences, including respiratory arrest and circulatory collapse. As with all medications used in medication-assisted treatment, naltrexone is to be prescribed as part of a comprehensive treatment plan that includes counseling and participation in social support programs.
And again, this is one of those scary things, right? That patient that may be using naltrexone or SUBOXONE for opioid use disorder and then relapses thinking that they need to use the same amounts that they were using before to get high, and that can end with the overdose. So having the Narcan or naloxone available and family members or persons that may be at high potential for relapse trains and that medication available to them is really an essential part of medically assisted treatment programs also.
So this just demonstrates what our MAT program consists of. So they get an LAC, Licensed Addiction Counseling Referral, which is done usually within the first couple days, and we do have walk-in slots available immediately. Mental health counseling is available, peer support, and follow-up care. And we start our clients out at once a week for 8 weeks, once every 2 weeks for 8 weeks, and then once a month. And depending on how the client's doing, they may have to stay on weeklies longer. It's individualized too.
The intake process is pretty streamlined with the medically assisted treatment program here, and depending on the severity of the patient's symptoms when they present, that would be up to the NP to determine whether this OUD is so severe that we're going to start this medication right away. Is it going to be a referral to another agency? Is it something we're able to treat here, right? And as Amy had said, we have LAC walk-in appointments available throughout the week, so someone may be able to come in opioid withdrawal or have a desire to change, right, and be able to see the provider, see the addictions counselor, and see peer support, like all in that same day, so just within a few hours. Oftentimes when working with addicts and alcoholics, you only have a small window of time that's going to be available to capture them and to initiate that recovery process. And so oftentimes if an individual walks back out the door, they're going to go back to drug use. And so by having all of these things available at walk-in times or having the medications and the counseling available right there, right away, is an essential part of the process, because every person that walks back out the door is somebody that we may lose to overdose or may lapse back into their addiction.
Yeah, that was one of my main goals, is I wanted to make sure and help people when they came in. So the whole process with insurance, Medicaid is pretty easy to work with. Private insurance takes a little bit of finagling. And then Medicare takes a little bit of finagling too. Sometimes it just takes a little bit longer, but usually somebody that walks in, we can get them started that same day. Sometimes people are so ready to quit with their lifestyle that they'll pay out of pocket for their first dose. It's about $11 a strip in Montana, so it's been, I mean, it's pretty expensive, but insurance covers it. Medicare and Medicaid 100% covers it. The private insurances usually have somewhat of a copay though. And then the ultimate goal of MAT is full recovery, including the ability to live a self-directed life. This treatment approach has been shown to improve patient survival, increase retention and treatment, decrease illicit opioid use and other criminal activity among people with substance use disorders, increase patients' ability to gain and maintain employment, improve birth outcomes among women who have substance use disorders and are pregnant, and decrease comorbidities like HIV and Hep C and all that some of our clients do come in with just because of the lifestyle that they've been living. So
as we heard our medically assisted treatment provider, Tara, say, MAT goals are all of these different things, right? Increased patient survival, substantial in retention, and all of those things do ring true. So medically assisted treatment isn't just about a prescription, right? It isn't just about a medication and replacing one chemical for the other. Medication assisted treatment does not work and is not approved for implementation by the FDA without counseling occurring with that. So that counseling has to take place in order for there to be the change also. So this isn't just a medicine-based approach. Working as a peer support specialist with our medically assisted treatment program here, I also work towards whole person wellness is one of my primary objectives. And so this is more of a whole person approach, right? Treating all of these different symptoms and treating the whole person rather than just treating the mind with therapy or the body with medications. So the state of Montana has implemented peer support certification through the Department of Public Health and Human Services just within the last year. So the training process takes place through Montana Peer Network. Montana Peer Network is peer run by people in recovery. It promotes recovery concepts of hope, self-advocacy, education, peer support, personal responsibility, and resiliency. The belief that these concepts are universal regardless of what recovery program you may choose. Montana's Peer Network has developed a comprehensive 40-hour training program that provides you with basic education and instruction around the most important elements of peer support work. This empowering and highly interactive training includes topics such as whole health recovery, one-on-one work, support group facilitation, ethics and standards, confidentiality, change model, recovery concepts, and much more. Peer support isn't something that is just going to go away. It's part of a recovery movement and a national shift from a maintenance model of behavioral health to a recovery model where every individual has access to care, choices, and that the message that recovery is possible. So although there is a 40-hour training program and a certification process through the Department of Public Health and Human Services in the state of Montana, those aren't the only requirements for peer support specialists. Peer support specialists additionally have to have the life experience, right? So peer support specialist that is not an addict or doesn't suffer from addiction would not be able to work one-on-one with a peer that does suffer from addiction. Although if that same peer did suffer from depression, they would be able to work one-on-one with peers that suffered from that same type of mental illness.
Someone just asked a question.
Did somebody have a question?
Yeah, it just came up. Somebody asked something about the training for peer support. I don't know how to. Oh, like right there. Bring it back up.
Yeah, click the chat there.
Yeah.
Okay, here we go.
Patients or staff. So Kristen asked if the 40-hour training for patients or staff or both.
So the 40-hour training is for persons in recovery. So the requirement is that you have 2 years or more in recovery from the mental illness that you suffer with or the addiction that you suffer with. And then you can go to this 40-hour training with the Montana Peer Network and become trained through them, right, through this 40-hour comprehensive training, and then the certification and licensing process takes place through the Board of Behavioral Health.
So really, it could be both. Patients can become peer support after 2 years of recovery and doing the peer support training, and then staff who have been, I mean, you have to be a licensed peer support staff to do like one-on-ones with people, so they have to have that training first. So technically, I guess the answer to your question is both. And then there's some training for like clinical supervision for peer support for providers or LACs, whoever does that, because I think somebody who is in recovery and doing peer support and hearing all of this all the time from people, it can be really stressful. So having somebody to check in with and make sure their mental health is okay and their recovery is still going okay, and then them working a program of recovery themselves is really important. I think Jason does a really good job with that. So
yeah, so for licensed or certified peer support specialists, it isn't like you go to a 40-hour training, you receive a certification, and now the ball is rolling and you're all on your own. Here at Helena Indian Alliance, I have a multi-tiered supervision approach. So I have direct supervision from both the nurse practitioner, who is the prescriber for the MAT program. She's my clinical supervisor. It requires 2 hours of clinical supervision for every 40 hours that are worked. You can't surpass working those 40 hours without that time of clinical supervision taking place. After that, I have my employment supervision, which is our clinic manager, Bonnie LaFontaine. Above that would be our director, who is very involved in the implementation and the continuation of the peer support recovery service here, and then the Board of Behavioral Health. So there's a multi-tiered supervision approach, so it isn't people just kind of going out and practicing willy-nilly in the community. It is something that continues to encourage recovery. Peer support recovery services are peer-based recovery support through the process of giving and receiving non-clinical assistance to achieve long-term recovery from mental health, physical health, and substance abuse issues. This support is provided by people who are experientially credentialed and trained to assist others in initiating recovery, maintaining recovery, and enhancing the quality of personal and family life in long-term recovery. The primary target population for peer supporters is people with chronic conditions of mental health needs, addictions, and or physical health needs, along with their family members and significant others. Peer support specialists are trained in mental health crisis interventions. They are trained and specialize in relapse prevention and relapse crisis intervention. Peer support specialists are trained to assist others in creating their personal advanced psychiatric directives. Peer support specialists are trained and specialize in suicide preventions and interventions. And peer support professionals partner with law enforcement, licensed mental health providers, medical doctors, and facilitate many other community partnerships.
So just in regards to that too, Jason doesn't just do in office. He'll take people out in the community as well. Like he's gone fishing with people and just like kind of like outdoor activities or things like that. So how it works it can either be a self-referral, somebody can come and say, hey, I think I need peer support, or me as a provider, I can do a referral, or one of the LACs or mental health counselors can also do a referral for peer support as well. So we have a couple avenues that can happen to make sure our patients are getting that whole person care.
It's a really unique and intimate relationship that's formed between a licensed peer support specialist and the peer. It takes place in a different setting than would be with a medical doctor, nurse practitioner, with a licensed addictions counselor. Those things are so serious. So this is something where the setting can be a little bit more relaxed. Peers participating in the program can feel as though the peer support specialist is relatable, and oftentimes individuals will disclose information that they won't necessarily disclose to their LAC or their doctor. The peer support specialists are able to relay that back to the team in order to provide that higher quality level of care. In addition to that, it improves retention rates, and it also encourages the peer support specialists to maintain their recovery also.
So our goals in continued medication-assisted treatment program of recovery are to treat those with opioid use disorder, and it's crucial to expand access to evidence-based treatments, including medication-assisted therapy. MAT is a comprehensive way to address the needs of individuals that combines the use of medication with counseling and behavioral therapies. So our goal here is medication is a very small part of this treatment, but to get the client in and show them a new way of life. And we're lucky here at the clinic too, because everything's under one roof. So they get to see their counselors, peer support, their doctor. You know, it's all in one clinic. So
one-stop shop.
yeah.
And then usually people who are, you know, getting clean and sober want to start taking care of themselves. So myself, along with another family practice nurse practitioner, provide just basic wellness and lab work and all that good stuff to make sure people are treating any underlying medical issues as well.
So I wanted to speak just a little bit again to the question about the 40-hour training, asking if it's for patients, staff, or both. As a peer support specialist, I do provide community outreach and facilitate different community partnerships. And in part of that, I do have a presentation that discusses peer support, more of the specifics like the ethics and the conduct of peer support specialists, what to expect when encountering them in professional settings and what not to expect of them, how boundaries are created, established, and maintained with peer support professionals. And that's something that I go out in the community and offer to a number of different organizations to bring, you know, both awareness and to reduce stigma that may be directed to peer support specialists that are in recovery and in professional roles also. So in addition to that, we've talked about the naloxone or Narcan training that we provide in addition to this training also. Yeah.
We have several support groups here too. We have a women's support group that we meet weekly. A couple of the addiction counselors have some group therapy, art therapy. There's a Rise and Shine group that we have that they involve exercise and giving back to the community a few times a week. So we have a whole bunch of parenting classes. Oh, help me out here.
We have a peer support group,
Yep.
Which is open to everybody, you know, in recovery or needing to be supported through any struggle in their life. We do have an AA meeting here once a week.
Yeah. You'll see in our pictures that we're going to present too that how much the clinic really offers different things like the Christmas presents we wrap for all the children and the Christmas dinner we fed, and there was like hundreds of people there. I just wanted to add too that the licensed addiction counselors are a huge part of this program. We don't unfortunately have one of them presenting with us, but they work very closely with the clients and do a lot of work with them.
So in learning about the Helena Indian Alliance, this is just our medically assisted treatment program, and I don't want people to get the wrong idea that we are like just a SUBOXONE clinic. We are an urban facility, and we offer a variety of different programs here that include youth programs, mental health counseling, and it's a family-friendly, safe environment for people just to come to be with their community also.
So this first picture, we have a display at Carroll College here at Native American Heritage Month. It's pretty awesome. And then this is our HIA staff group at our Christmas party. And this was the Christmas turkey dinner that served the HIA. There was hundreds of people for that. Cooked about 10 turkeys, I think.
Mm-hmm.
And then the drumming and music at the Round Dance Day. This was wrapping Christmas gifts for the children to get from Santa. And this was our Fun Day Run outside event.
Yeah, this is the HIA youth program preparing for back to school and getting supplies that are needed. The HIA staff picnic, do this once a year. Boardroom where we have some important meetings, maybe some not so important meetings. No, I'm kidding. This is just the clinic, one of the nurses' station or MAs where they hang out. This is the main entrance into admin. This is one of the patient rooms that we have. This is our new waiting room. It just got remodeled last year. We love it. Boardroom again.
And that's the end of our presentation. And thank
So
you.
I would encourage everybody to go to the HelenaIndianAlliance.com and visit our website so that you can see the Indian Health services, urban facility, list of all the different services that we offer, staff that we have here, and more thorough photo presentation there.
Mhm.
Is there any questions that anybody had at all?
I was going to say, that's our next stop. Who has questions?
I was curious, this is Mark Clark. I was curious, you mentioned having an AA program, and there may be people who think that the medication-assisted treatment is like exactly the opposite of AA programs or 12-step programs. Can you discuss how you would answer that kind of question, that people think that you can only do one or the other?
So the AA meeting that we have here, we just allow Alcoholics Anonymous to use one of our meeting rooms on a Sunday morning for that meeting. I know that some AA groups are open to all different types of treatment. Following a 12-step model can be very valuable and very important. And I do have some medically assisted treatment patients that do follow a 12-step model.
Mm-hmm. Yeah, for sure. You know, again, recovery is lifelong, and whatever works for the patient works for us. If they think that they do better and can stay sober going to AA meetings as well as coming here and doing addiction counseling and being on medication, then that's great. We totally support our patients in whatever they'd like to do for support resources anyways. So I would say, you know, it's really up to the patient if that's something that they feel like they want to do. Not all the time do they disclose that they're taking medication for medication-assisted treatment to people in AA, because I know that that's, there's just some different thinking there. However, I think the statistics for AA people, you know, staying sober is like 1 out of 10. So I feel like our program of, you know, 80% of people stay sober after a year is huge. And the fact that medicine has come this far to help people and support them any way possible. I mean, that's our end goal, is to keep people sober and help them be contributing members of society.
And absolutely, Mark, I can agree 100% that Alcoholics Anonymous or Narcotics Anonymous often is an abstinence-based program following a 12-step model. Although I do want to reiterate, you know, myself and my personal experience, there is one AA meeting that I go to weekly, and I've disclosed that I've used medically assisted treatment and I'm a proponent for that. And everyone there has been open to it. It's been, you know, if that's a medication and that's something that works for you to keep you in recovery, then that's great. Another alcoholic in the room says, I suffer from depression, and so I take this tricyclic medication in order to control my depression, and that's okay. And so I think oftentimes individuals in AA may view it as a medication to help control the symptoms of alcoholism and or addiction, although not always. There is also, you know, the other stronger opinion that abstinence-based is the only way, and I get that. I respect both of those models.
But you gotta do what works for the patient. Yeah. How about anybody else? Does anybody else have any questions?
Oh, could I just, well, if there are any questions, well, I'd just ask, maybe you could discuss for a couple of seconds what you would recommend for an urban Indian health program that's interested in offering MAT. What would you suggest they should do as their next steps, or to pursue that interest further?
Sure. So the biggest things are just getting an X-waivered provider. There's a little bit of a stigma provided with it, and if you don't have the education or knowledge surrounding it, then it can be a pretty big bear to tackle. I've done a lot of research and I've learned a lot in the last year. There's a 20-hour training that nurse practitioners and PAs have to do, or 24 hours. And then there's an in-person 8-hour seminar that you go to as well, that teaches you quite a bit just about the whole medication and how this program has helped so many people. So that would be number one. You have to have your provider. Number two is getting a clinic coordinator, like Amy. And And then from there, with Bonnie's help, and then peer support and addiction counselor, having all of that, we did a lot of research on the policies and procedures, and how often we were going to UA people, and how often we needed to see people, and coming up with our contract that's been tweaked a few times because we've just had some more education, so then we tweaked it a little bit. Some of the newer stuff that kind of came down the pipe about with medically assisted treatment is allowing people to have abnormal urine results, but addressing why they relapsed. So say for instance, maybe they have like an untreated mental illness or unmedicated mental illness, or they're having increased stress at home. So the SUBOXONE really does help with stress and those kind of just life in general. And then maybe they need to see their addiction counselor more frequently, or maybe they need an increase on their SUBOXONE or something like that. So the biggest thing that someone can get kicked out of our program for, because a provider for the first year can only have 30 patients, which I'll tell you what, I got there in like probably 4 months, because people come every single day or call every single day if we have any openings, because there's just not a lot of providers in our area. So with that being said, you just have to really keep good tabs on people, and just make them very aware of the rules and compliance, so they can get kicked out for just not attending the groups. So not attending their appointments, or peer support, or addiction counselor. So if they have 3 no-shows with any combination of the above mentioned, then they're out of our facility for 6 months. So we do give them options of other people that they can get their medications from, but we really just have to keep really good tabs on that. So that's just my one piece of advice, to just make sure you have very clear boundaries and expectations for your patients, and you bend the rule for one person and they're gonna pass that on to everybody in the community. So we learned that the hard way.
And so as far as for individuals looking to implement medically assisted treatment programs at other urban facilities, education is probably one of the main priorities that the staff as a whole needs to have. And as far as grant funding or reimbursement, alternative payment models, that's an entirely different thing. And I would encourage individuals to, again, to visit our website and maybe send an email to our director with some further questions about that. He may have some more answers as far as like alternative payment models or grant funding that's available in Montana specifically for that. So that's a big part of the right.
That's excellent. So you're open to people contacting you who might have additional questions.
Absolutely.
Absolutely. Yeah, please.
It's a learning process. We're still learning.
And how long has your program been in operation?
Well, so for myself, I've been prescribing since May, but there was a prescriber prior to that here that was doing it for 4 or 5 years before that. So
as far as having our program up and running and following the model that we're currently following with Tara, myself, and Amy, it's been just right under a full year.
That's good to know.
We took the train wheel.
Yeah.
That's great. That's excellent. I wanted to let our audience know that we're going to send out a follow-up evaluation form by way of email, just to stay in touch with people who are part of this community of learning.
Great.
We'd actually scheduled a 90 minutes, but unless there are more questions or more dialogue that the audience is interested in pursuing, I just thought I'd alert you that we're going right into the 3 p.m. hour now, Eastern Standard Time.
I do have one question. This is Kristen in Wichita, Kansas.
Hi, Kristen.
Okay, good. You're hearing me. I am wondering if you have any peer review from outside your program to watch and see how your program's going and offer pointers before it would become any sort of quality issue that you weren't aware of.
So thanks for the question, Kristen. Recently, we had Brandon from the state who's working on the SOR grant to fund the MAT program, expand the funding of. And so we had interviews all day lined up of multiple different kinds of clients, including past, current, staff, the counselors, and so people actually participating in the program were interviewed as well. And we discussed that.
Yeah, so it was a full 8 hours of non-partisan, non-interested parties that came in and interviewed different patients, as well as the staff that are working in the medically assisted treatment program to see what's working, what's not, and how can we maybe fix any bugs that we are unaware of, the quality issues that people may not bring to our attention.
We're actually waiting for the review of that too. So
the biggest concern from that was just with the STR grant that we have funding under right now, up until the end of this month, right, or next month?
it's done.
Yeah, okay, I think so. So is the hub and spoke model. So that was, and that's just in regards to, like, we would be a hub and say a town, I don't know, 60 minutes away from us would be a spoke. They would have their own provider, but they would just kind of lean off of how we were doing things and kind of model that. So it just hasn't really worked like that, though. People have just kind of branched off and did their own thing, obviously according to like SAMHSA and all those guidelines that people have to follow for medically assisted treatment. But that was one thing. So the thing that they're kind of changing about that in the new grant is kind of webbing instead. So having mentors for your providers or for your LACs or peer support in other facilities. So if you're having a difficult patient or situation, you can contact them. So just kind of having just people available. And I do have a few people available that I talk to that have been doing this a lot longer than I have, that I appreciate their feedback and things like that. So that was one change that was not working before. So I know that that's one thing.
Good, good.
Cool. Are there any other questions, or did you have a follow-up on that question?
No, thank you. That's helpful. Yeah, I need to develop that network myself. I was part of a very well-established MAT program in Bangor, Maine, and then I moved to Kansas, and we're just getting our program up and running now. So developing those networks, I think, is going to be key for our clinic.
Absolutely.
Yeah, and it takes time to build that. I think in Montana, and specifically in Helena being the capital, we've really been at an advantage with all of the funding and education and time spent towards the opioid crisis. It's helped to enable us to build that networking structure with the state of Montana and primary insurance providers hosting a number of different conferences and events where we're discussing opioids and opioid use disorder and how to combat and curb the opioid crisis nationally, and not only nationally, but in Montana. So yeah, building that network of individuals can be a lot of work.
Yes.
Yeah, but yeah.
You can definitely email any of us, and we can get you some of our contract policies, language kind of that we've developed over the last year and changed. I know that was really hard to kind of come up with from scratch. We did a lot of Googling, so but we've definitely worked really hard, and we're really proud of what we've done thus far. I think another thing that's really important is having the mental health services available. I was actually just reading an article about ADHD and how when it's untreated can cause an increase in substance use disorder. So just making sure you have a provider or mental health services available to address those mental health issues as well. because I would say probably, I don't know, 80% of the patients that I have were self-medicating with opioids or other illicit drugs to cover up symptoms or to treat symptoms of a mental illness.
Are there state or federal agencies you would suggest people could check in with to find out more about programs that might be available in their local area?
So SAMHSA is always a reliable source for anything that is generally modern as far as looking for available sources that are medically assisted treatment or OUD specific in areas. I think SAMHSA is one of the only resources I know of.
I would say the Department of Health and Human Services at the state would be able to give you some good resources as well.
That's very helpful. Thank you.
Mm-hmm.
I have a quick question, if I could.
Sure.
I work at an urban Indian health center in Kansas City, and I have referred several clients to get medication-assisted therapy. I'm certified in it. And the problem that I have, I'm a solo practitioner here, and we don't have a health center here, so there's no physicians, no nurse practitioners. And what happens is when I refer these people out to an organization that can give the medication, they require them to go through their substance abuse counseling at their facility.
Right.
And I end up losing my clients.
Yep. That has been a problem for a few people here who have tried to do it like that. I feel like the one-stop shop makes it really easy for people. So I mean, I don't even know if maybe like telemedicine would be an option for you to, I mean, I know you're in a private, but see if like a nurse practitioner or PA or somebody could like do a telemed and they could come in and do their UAs there, and you could do the counseling and they could see their provider and then make it an integrative medicine. Yeah.
It's another one of those things that is unfortunate when working with person suffering from OUD, that a facility is going to require them to use their counseling only specifically because that may scare someone away, right? Like, I want to use my counselor, but I need Matt also. So if we experience that type of situation, we're always willing to work with somebody and to work with their outside provider, as long as we have that ROI and we're able to communicate back and forth, just visit dates, or like if there's something serious that we need to know about. That's what matters to us. But being able to facilitate whatever individualized plan works for each individual is a really essential part of medically assisted treatment.
Yeah, we work with several private counselors out in the facility or out in the community, and we just keep in contact with them. If patients have a rapport with that counselor, I am not the one to say nope, you can't do that anymore, because I feel like that could be a trigger for somebody having to tell their story all over again and build trust in that counselor and things like that. So we allow people to see addiction counselors outside of the facility.
Right, that's exactly what has happened with a couple of people. I've been seeing them for over a year, and offered that as an option after I got certified in medication-assisted treatment, and they required that. Clients got upset because they already had a relationship established here, and they ended up going back out and put a needle in their arm. So I'm really frustrated about that.
Yeah.
Yeah, it's about reducing that stigma, I think, and just education also. So, you know, just finding that information that proves those facts and then sharing it with the community, you know. I'm surprised that people aren't open to, it genuinely surprises me to find that out, that people aren't open to somebody using a different counselor and prescribing medication to them.
And it just might need some just education, honestly. You might just need to go there and be like, hey, so this is what I'm doing. You know, these are my goals for these patients. I feel like this could be a trigger to have them move to a different counselor. We've done a lot of education in the community with like CPS and PO officers and all of those people to kind of help reduce the stigma along with medically assisted treatment. So I don't know, maybe they just need some more education on like what you do, and maybe they just, I don't know. I'm giving them the benefit of the doubt, I guess.
Yeah,
I like your idea of contracted telemedicine with a physician and nurse practitioner. I hadn't thought about that, so that might be an option.
It's huge, and somebody could do it from their own home. I mean, I do telemed for a couple patients in Browning, which is about 3.5, 4 hours away on a good day. So with the lovely snow that we've had this winter, it has not been a good day. So that limits our travel time. But we've got Skype and we've got like Facebook video or whatever that I use to have interactions with my patients, and then just call in a prescription that's close to their home at their firm.
I'm going to investigate that. That's a good idea. Thank you.
Yeah, absolutely.
Yeah, we've been really well provided for by our urban agencies in the fact that they have allowed us to provide all this different education to the community. And so I've seen a fairly dynamic shift in opinions from a year ago towards medically assisted treatments to today. We have opinions in the community towards medically assisted treatment. So we've again gone to agencies like Department of Transportation, Child and Protective Services, Probation and Parole, the Sheriff's Department, and provided them just with an education that's similar to the one today. What is Suboxone? What isn't it? Why is it prescribed? And how is it controlled? How do we help to alleviate diversion concerns? And that's one of the important parts, is because it is a controlled substance, alleviating those diversion concerns, not only amongst other professionals in the community, but also professionals within your own agency. Any other questions at all? Going once, going twice.
How many, sorry, another, just before the doctor here, how many,
The auctioneer voice worked, didn't it?
no, how many patients that are discontinued from the program come back after their 6 months and they're ready to go again?
So I think we've had 2. Off the top of my head, I think there's been 2 that have come back after being off for 6 months. And then 1 didn't last very much longer after that. Yeah.
So yeah, working those numbers in my head, it's, maybe like less than 10%
Yeah.
of those persons that
Yeah,
or
about
less
2
than
people, and that's out of 70
1%.
total.
Yeah, of those persons that are discharged, so less than 1% come back and are successful.
Yeah, we've, my program currently is 3 months, and I think in Bangor, I think they even shortened it a little bit more.
Sure. Yeah.
To see if they, to remain available. Of course, they're out in the middle of nowhere, and there weren't many other providers, so they really wanted to give people another chance.
That's a great idea.
Yeah, that's good to know.
I know we actually just talked about this the other day about do we leave it at that? Do we leave it at the 3 no-shows and then you're out? I mean, there's a lot of other programs that, like, you miss 1 appointment and you're done. So, but I think those are more of the programs that maybe there's a lot of providers in that area, so they make it a little bit more strict. But when there's not a lot of providers, like probably where you're at and definitely where we're at, there's not a lot of providers, so it kind of maybe increases diversion rates, things like that, unfortunately. So that's a good idea.
Yeah, it is a good idea. And as we all continue to learn more about this medically assisted treatment thing, thinking changes, right? And the information and the data that we have available changes. And so from my understanding, more recently, removing people from medically assisted treatment and taking that option off the table for people just is like adding another barrier to their life. And so having it available is important, but also having buy-in from the person in recovery is important also. So if somebody isn't going to make any of their appointments or receive any counseling and they just want just the medication, that wouldn't be following the standards, how I understand the assisted treatment to work. but then it's a two-sided thing for me because they are now are they sober, and they are sober. So yeah, it's a difficult question.
Mm-hmm.
Yeah.
And you mentioned you have a program coordinator to just track whether patients are keeping appointments, any, medication counting that's off and such. Is that somebody's full-time job, and how many patients are being tracked?
Yeah, I'm Amy, so I'm the MAT coordinator. I'm a registered nurse, and yeah, I do the tracking and keeping track of appointments, and Tara keeps the tracking as well. And I communicate that to the state for their data input. And also just go through their appointments. We keep an Excel sheet that has on it when they were last seen, their last scripts, their last UA, etc. So it's one piece you can just look at. And also our appointment, it's called Moonwalk. You can just pull that up and it has every single appointment in there that they've made or missed, etc. It is a full-time job at this point, yes.
For how many patients?
For 30. Tara keeps 30 and she's expanding to 50 in May.
I could go up to 100,
Yeah.
but I'm going on maternity leave in August, so I don't want to stress everybody out too much before I leave for a couple months.
And our MAT coordinator does so much more than just like track
Yeah.
patients, information, and data. There's so many more duties that go into that. The position isn't similar to a charge nurse, but I do think that she does some patient interaction and those types of things. But it's really like a kind of a community coordination role within the medically assisted treatment program and inside our facility, and then communicating with outside agencies that are specific to this program also. So it's a really valuable role, and it's a necessary part of our program here.
Okay. Amy, would you be willing to speak with me at a future time? We're trying to decide exactly how to create that role within our program.
Sure, yes, that'd be great. Be happy to.
Oh, thank you so much.
Yeah.
I was curious, you mentioned that wait list. Is there anything for those people who might have lengthy wait lists? Are there any special provisions that can be made for persons who are in that kind of waiting status with regard to, I don't know, their own addictions, or I don't know, special concerns or even social concerns while they're waiting, but they're kind of in that kind of gray area where they want to get into treatment but aren't able to because of the wait?
Sure. Yes, so I do offer a Vivitrol injection, which is just the naltrexone. It's a monthly injection that does not count against my numbers for medically assisted treatment, but it's used for opioid use disorder and alcohol dependence. So if I can't get somebody on the SUBOXONE because I'm full, I do offer that to somebody, as well as other options of where to find the SUBOXONE at. And then we do get them hooked up with counseling right away, and then any other mental health needs that they might have. We do have a case manager that does just specifically housing. We have another gal, like a patient advocate, that does just specifically insurance stuff to help kind of navigate through that whole system. So we do attempt to help them in some way. I've also given people like a couple days worth to get them through a withdrawal instead of finding something else off the street, to build a rapport with them. And I don't think it's necessarily something that you should do all the time, but I know sometimes that there is a clause in one of the Data 2000 thing that ER physicians can prescribe up to 72 hours of SUBOXONE. So I kind of just liken it to that and say, here's a couple days to get you through the weekend. You need to go see so-and-so on Monday or whatever. So yes, I will do that to just, to prevent an opioid overdose or a heroin overdose.
Outside agency referrals can be an important or valuable thing also, and that's one of those places where peer support plays a big role, is that intervention piece when there is a wait list and there isn't a way for them to start this program right away, and there's no way they can get to an outside referral source. And so helping with all of those different social pieces that go into that, and then also assisting with all of the social pieces that go into initiating recovery, and what does that look like when I'm first getting into recovery and my whole life is changing, right?
Mm-hmm. Right.
Yeah, so we do everything, definitely, like Tara said, everything we possibly can to help with as many options as we can when medically assisted treatment right now isn't exactly an option.
That's great. Thank you.
You're welcome. Yeah. All right, guys. Anybody else have any questions out there?
Well, I suppose we've come to the end of our today's community of learning. I want to thank the Helena Indian Alliance for giving us such great information and agreeing to make themselves available for those who may wish to follow up with them to get additional information. As I noted previously, we'll send you a thank you for your participation in today's community of learning, and also an evaluation to follow up on this particular session, and look forward to hoping you'll join us for our next community of learning. I'd encourage you to stay in touch with the National Council of Urban Indian Health via our electronic newsletter, or keep your eye out for our next advertisements for either a community of learning or webinars or other opportunities to exchange knowledge with you. Having said that, I wish you a good afternoon, and have a wonderful balance of your week. And thanks once again for joining the National Council on Urban Indian Health. Have a good afternoon, everyone. And thank you everyone at Helena. I appreciate your sharing so much with us.
Helena, you're welcome. Yeah, have a good night, Mark.
Have a good week.
All right, take care now.
All right,
Take care.
Not Helena.
He said it though, finally.
Bye-bye.
Bye.